Oh, thank you for having me. I'm having such a wonderful day. We've had such incredibly talented speakers and performers. And I'm conscious that I'm here today to speak to you about an energy-based device. And that doesn't sound so entirely exciting, but I'd implore those of you who don't have the energy-based device that I'm going to speak about to just be open-minded, because this is not just any energy-based device. This is the device that changed the way that I practice the whole of aesthetics. And I want to take you on a journey through what this device can do to elevate all of our clinics, potentially. But before that, I want to introduce to you that we have elevated the device. So Ultherapy has now become Ultherapy Prime, microfocused ultrasound with live visualization. And Ultherapy Prime can elevate our practices because it enables us to treat a multi-layer of anatomical structures that we can't treat in any other way. We can't access them. We can't treat them as accurately with any other device. And I consider Ultherapy Prime to be the intellectual energy-based device. And the reason for that is because it's a super smart device, but it engages us in remembering that we're physicians. We have to always remember our anatomy and physiology and the psychology of the patients when we use this energy-based device. So it asks us to step up and be more intelligent in our approach to energy-based devices. And I hope that I can share with you why that is my view. So just have, obviously, the usual disclosure. These are my opinions, obviously, and there is some off-label use of Ultherapy and Radiesse in my presentation. So who doesn't love a Volkswagen Beetle? But how many of you would actually drive a Ferrari? So interestingly, I was actually in Germany yesterday training in the home of the VW Beetle, and yet today I find myself here in Bella Italia, where you have designed the supercar to end all supercars. And I actually think that our new Ultherapy Prime is the supercar of energy-based devices. It has a beautiful design, it has a superior technology, and yes, it drives faster. So we have now a really state-of-the-art device. The main key characteristics are that the visualization, which has always been there and has always been live, is now more vivid. They call it vivid visualization, but you actually can see down to deeper layers of the tissue, and the tissue you can see has more definition, so you can actually discern the anatomical structures you're trying to treat. It also has advanced technology, which will build for the future. So it feels to use like a completely different device. And it's a platform for the future. So when there are upgrades in future, we will be able to plug them in. So it's evolving. The device has evolved technologically so that we can continue, because we don't stand still in medicine. And instead of having to replace an energy-based device with the new model, what we can do is upgrade this, which is more sustainable. So just to drill down on the details, and obviously not a lot of you have Ultherapy. Could I just have a show of hands to see where my friends are? Okay, we're few. We have to stick together. So the visualization is more clear because the interference has been dialed down. So you see the layers with much more clarity. The screen, the overall screen is bigger, and the screen that houses the ultrasound component is bigger, almost twice as large. So this enables you to see the anatomy. And we must remember, this is an ultrasound-guided treatment. How many of you actually do ultrasound-guided treatment? How many people have high-definition ultrasound? High-definition ultrasound, only one? Okay. How many of you use it to live guide your treatment? Okay. I do actually sometimes use it to live guide treatment because I find it so difficult injecting now without ultrasound because I'm so particular about the tissue I'm treating. And I have been moved to that view by spending so many hours doing ultherapy treatments, where every time I deliver part of the treatment, I know exactly the target that I am attending to. The advanced technology means that it's much faster. So for therapy users, that means there's no latency before the image comes back. You deliver a shot, the image is there immediately again. So that makes it about 20% faster to deliver the treatments and 100% more pleasurable. And there's a faster processing speed so that the screen is more touch responsive. Everything about it feels like a sophisticated device. And like I said, it's progressive. The updates as they come, the improvements to the way that we treat will be able to hopefully be present on the device. So when we treat with therapy, and generally when we think in aesthetics, we think in terms of roughly parallel layers. Certainly with therapy we're treating layers progressively deeper in the face. But as we know, and as the theme of today has been, everything's interconnected. And the layers of the face are interconnected in 3 dimensions, and you all know that because you've all studied anatomy. And yet, for so long, we've been talking about layers of the face as if they're individual components. And one of the beautiful things about the Therapy Prime Vivid visualization is that for the first time, as we're live treating, we can visualize how those layers are interconnected from the dermis through the fibrous septi, down to the SMAS, and even below to the retaining ligaments. So we can think in 3D, we can create 3-dimensional images of the internal anatomy of our patients, and we can treat them as such. And with therapy, our prime target is the SMAS. And as far as I know, I can only treat the SMAS with therapy. I'm not a surgeon. And I wouldn't dare put anything else down, any other energy-based device down there, because I would be worried I would hit a target that might be disadvantageous. But with Therapy Prime, I know exactly that I'm treating the SMAS, even which part of the SMAS I'm treating. But SMAS is not one layer that's a simple straight line or parallel lines. It's a really complex composite structure. So you have wavy collagen and thin filamentous elastin fibrils, and it's all interspersed with fat cells. And obviously, in between segments of the fat, you have the muscles of the SMAS, you have the muscles of facial expression. So this is a complicated structure, and we need complex ultrasound device to be able to visualize it and treat it accurately, and that's what we have been given. So this is a high-definition ultrasound picture of all the layers of the face to the zygoma. I haven't visualized it deeper because I wanted it to represent roughly what you'd see with therapy. This isn't the Therapy Prime image. It is one of my high-def images, but there's not a huge amount of difference. But this is roughly what you'll see when you're treating with therapy. And you can see I've marked the zygomatic bone. And on the left-hand side of the screen looks very different than the right-hand side of the screen because obviously we're moving from the zygoma medially into the cheek, and so you don't see the bone, you don't see any periosteum on the right-hand side. But for those of you who aren't so familiar with ultrasound images, what this is enabling us to see, and I've labeled it, you see the epidermis as a white stripe. You then see a nice thick dermis that here is almost 2 millimeters thick. So this is a good dermis. You see that the underneath of the dermis, the reticular dermis isn't flat, it's not a straight line. And yet I've been trying to treat it as such. It actually comes down and joins into the retinacular cutis, those tiny little fibers that join then the fibrous septi that run through the subcutaneous, and they connect into the SMAS and then arch down into the bone, a bit like a tree. We talk about the SMAS as a tree, don't we? It's rooted in the ground, and the trunk comes up until it reaches the underside of the SMAS. The branches become the SMAS, and the smaller branches reaching to the sky, to the dermis. And it's all one interconnected piece of nature, like a tree. So you can also see on this image that the SMAS, which I've marked, you can see clearly, is different thicknesses. So even as a structure, it's not consistent. And I don't think we really understand enough about this anatomy that I personally love to treat. I also love to inject, and I understand, we all have an elevated knowledge of injection anatomy, of toxin anatomy, of surgical anatomy, but the anatomy of this elusive three-dimensional collagen-rich network, we don't really understand. We don't understand enough about its structure, generally or in an individual, because everybody's SMAS is different, I can tell you, because I look at anyone's SMAS who'll let me look inside their face. And not only is every anatomy different, but this is a mobile structure. There's a concept called tensegrity, which my husband, who's an osteopath, taught me about, and it comes from musculoskeletal medicine. And the concept of tensegrity is that you have a balanced ligamentous tension between mobile structures and rigid ones. So in the body, you'd have a balanced tension between the bones and the myofascia. And everything is in harmony. And we all know in our bodies, in health, and in the world in general, disharmony is disadvantageous. And the aging process creates disharmony in that tensegrity of the face. That's what laxity is. So you get an imbalance, and then these structures we're trying to identify, they're not in the same anatomical position. And we get ptosis of the face. And then we're trying to treat anatomical structures when they're in a different position because they have sagged. So I think it's really important to think in layers, but I also think it's important to integrate our thinking. Talking of layers, though, Sebastian Cotofano made a very stylish dissection to demonstrate the layers for us. And to concentrate on the layers we treat with therapy, it's the superficial fascia, layer 3. It's the subcutaneous layer, which we're not aiming for fat, we're aiming for the fibrous septi to try and tighten the fat layer and to sculpt it. And we're treating the deep side of the dermis. But as we've just covered, the layers are not so tidy. I've been trying to treat them with oil therapy like this for years. This is an example of how you might use an oil therapy device. So we have 3 transducers. We have a 4.5 millimeters in an average face that's maybe the age of 30, 35. Then the SMAS would maybe be at 4.5. In my average patient who's 60 and photodamaged, because I live in the UK, and the first thing people do in the UK when the sun comes out is go in the garden or get on a plane, because we rarely have sun. A lot of sun damage, even though I don't live in a sunny country, because we don't have much melanin. So my average patient will have their fascia at 2 millimeters. So every face is different, but in this face, the fascia is at 4.5. We can apply pressure and release pressure, and that's why I've done a line at 4.5 and then slightly above. So with an ultrasound-guided treatment, you can change the way that you use your transducer to access different parts of treatment. So it's not like any other energy-based device where you're looking at the time or reading your text. Not that I would do that while you're delivering the treatment. But you need absolute concentration. You're delivering treatment, looking at the ultrasound guidance. Every single shot has to be precise. This is why I say it's an intelligent treatment. And when we're treating the fibrous septi, the fat is more compressible, so we can change, increase and release our pressure, access different structures. And with the dermis, if your dermis is 1.5, that's perfect. If in a dermis, like most of my average patients, we don't always have dermis at 1.5, in which case I will pre-prime with hyperdilute radiesse to improve the dermal health and thickness, the skin quality, and then I'll deliver oil therapy in that LR. So this is one of Sebastian Cotofano's dissections also, maybe one of his earlier ones. It wasn't quite so flamboyant, but it shows really the true anatomy, which is that it's all mixed up together. We don't have tidy layers. And we have to adapt to the anatomy that we have, which is actually, it's all interconnected. This is what my eye sees. I've drawn it on the ultrasound image to give you an impression of what lights up in my brain when I'm looking at someone's face. And I'm trying with every depth of transducer I have to access as many of these little wavy lines that I've drawn on that I can, because every one of those is a collagen-rich tissue. And the reason why our patients come to us isn't just volume loss and muscle imbalance, it's laxity, multi-layer tissue laxity, and I want to address every single bit of collagen-rich tissue I can to improve the laxity. So this is, just to orient those of you who are not familiar, we have just level with the 0.5 mark, that's roughly the SMAS. Below it you have the masseter muscle, and the dermis is the white above. And for those of you that know all therapy, you'll get what I'm doing. So this is a video just to show you that even in treatment, it's dynamic. I'm turning the transducer, so I'm being able to see that suddenly I can find straight lines of collagen-rich tissue to treat that weren't there before. So again, it's not just an intelligent treatment, it requires me to be dynamic and active. I have to seek my target. It's a really enjoyable treatment to deliver. I look forward to all therapy treatments. And you can see what I'm doing here is lifting the pressure so that I'm actually creating a thicker tissue. I can now compress it, and I'm creating a thinner tissue. So you can see live how you're changing the tissues under your fingertips. Now, we change the tissues under our fingertips when we inject, but we can't see it. And it's really a very satisfying way to deliver a treatment that you know exactly what's happening on the internal anatomy of your patient. But before we even get to internal anatomy, every excellent treatment starts with an excellent consultation, assessment, and diagnosis. And I spend no less than an hour with a patient because I want to leave no stone unturned in making sure I can give them the best diagnosis and therefore the best prescription. So our consultations will obviously, like all of yours, drill down into the patient's concerns and their expectations. But during the consultation, we're also looking at medical reasons that would support or detract from regeneration. So sadly, I don't speak Italian, but I think in the introduction there might have been something about the fact that I practice integrated medicine. So I'm trained in Chinese medicine and various other forms of medicine, as well as Western medicine. And my joy in medicine is helping to create balance. So imbalance is disease, balance is health, and other world medicines seek to rebalance the health of an individual to alleviate their symptom. A lot of the time in Western medicine, we suppress the symptom to alleviate the patient's concern. So my approach to aesthetics has always been to try and treat the underlying cause wherever I can. And so a lot of my consultation is trying to understand what bothers a patient and why now in their life, what's happened in their psychology or in their life events, what triggers might there be, but also in their general health. Can their general health support my trigger to ask them to regenerate? Because I use a lot of therapy and a lot of radies and their regenerative treatments. I need my patients to be able to grow healthier tissues. So we spend a long time consulting, and then I get my hands on the face. We're talking about laxity. How do you know how saggy somebody is unless you play with their face? So I stretch people's face. How elastic is it? How much surplus tissue is there? Have the fat pads moved from where they should be? Usually yes, even in a 30-year-old. So I want to know, if I migrate with my fingers, the fat pad up the face, how far do I have to move it? In other words, how high is this mountain that we have to climb together? And then after palpation, photography, obviously, we have visio and vector analysis, because assessing change in laxity in a face is difficult even for a physician, let alone a patient, to understand all those minor changes that they saw, that they know they look better, but they can't work out why. So really good photography is essential with something like all therapy. And then the ultrasound we've covered. MEXS scales, or any other assessment scale, is particularly useful in all therapy. And the reason is that we are tightening laxity, and I can measure it with my fingers, but I have no idea what's in my patient's mind. So I ask them, where do you think you are on this grading scale? And if they think they're a 1, but I think they're a 4, then that's a conversation before we even decide whether to treat. But if we agree on the same grade, then the next question is, okay, we agree that you're a grade 3. If you want to move to a grade 1, I can't do that with one treatment. So then it's a conversation about the journey that I will take you on, and one cycle of treatment may move you one grade on the laxity scale. So consultation and aligning with what's in your patient's mind is key to success. Obviously, I don't just do all therapy, and I love injectables as much as everybody else in this room, but I love injectables when injectables is what is required. If you have laxity, I want to tighten your collagen-rich tissues with all therapy. But if you have structural decline, so bone loss or fat loss, then I will apply the appropriate treatment, and the same with muscle imbalance. But even more importantly than my journey is the patient's journey here. It's about education, educating that patient that comes with skin laxity and showing them I have a skull on my desk, and all my patients know about the coat hangers, the coat hanger that is the jaw, the coat hanger that is the zygomas, and the brow. And if they have a narrow bigonal distance, for example, I'll show them anatomically and explain the reasons why I need to put the support in before the all therapy. Because even great as all therapy is as a treatment, with such a body of evidence to show its success, all therapy won't show its best result in a patient that doesn't have the bone support. So we've covered that we assess the anatomy. I've touched on physiology, but I'd just like to drill down there a little bit, because my patients are all trained to understand about promoters and detractors. When I take a medical history, I'm looking in the medical history for a promoter of regeneration or a detractor of regeneration. It's kind of like points. And if they have promoters of regeneration, so in other words, they sleep well, they eat a good diet, sufficient protein, better still, maybe they take a collagen supplement, they have lots of antioxidants, a punnet of blueberries every day. If they have lots of promoters to regeneration, then I'm more confident they'll have a good result. On the converse, if they have poor sleep and high oxidative stress, if they're in menopause without any hormonal support, then they will have a lower result from my regenerative request to their tissues. Lifestyle, the same. Smoking, big detractor. Alcohol, sadly, also quite a big detractor. Poor nutrition. Good nutrition, exercise, blood flow to the face, etc. And I give my patients a little anti-aging clock to try and stimulate change, because when someone comes to my clinic, there's been something has happened internally to make them want to seek my help. So they're usually in a place in their life where they want to feel better. And that's a really special, pivotal moment. So I harness that pivotal moment by also teaching them about changes they could make in their life that would give them a better return on their investment in all therapy. And there are 12 hours on the clock, and there are 12 months in a year. So I tell patients, just make one change every month. It doesn't have to be all at once, but small changes sequentially make a big difference. So we've done the assessment and we have done a plan. Then we have treat. This is C-Plan Treat. Now, C-Plan Treat was born in my clinic because when I got all therapy, probably more than a decade ago, I followed standard protocols. And not surprisingly, when we follow standard protocols, we get standard results at best. And patients said it was painful, and that I thought it was not effective enough. I audit every patient every time. And within a short space of time, I went back to first principles and I redesigned how we did the treatment. And in that redesign, we then ended up with, in our study, 100% of positive results. So previous to customization, about 60% of people were satisfied. When you customize a treatment, which you can with live visualization, 100% patient satisfaction. And the treat part of C-Plan Treat is all about customization. Customization to be accurately on the target, treating that collagen-rich tissue, but definitely not treating the bone. And there are other devices that from reports of adverse events, must be hitting adverse targets. So if you can't see, then you can't avoid the bone, the masseter muscle, the parotid gland, for example. So accuracy is key. And then there's individualization. We individualize with everything we do. You choose exactly the dose of filler that's required for that individual patient. We do the same with all therapy. And we adjust the dose to the size of the area, to the thickness of the tissue. We also think about the density, like we do with a filler. You might put more in one area than another. We can do the same with all therapy because it's a guided treatment. It's a very discerning treatment, and we distribute it in the areas that need it the most. Orientation is something that all therapy practitioners will know, but what that basically is what direction do you hold the transducer? So if that's my all therapy transducer, the energy, the microfocused energy, about 20 little thermocoagulation points, are delivered in a line. And if I deliver them in one line versus at an angle, it will have a different effect. But also, I'll see different things. So when I turn my transducer perpendicular, then I can see different targets. So that's the orientation. It's a very dynamic treatment. We're moving to target precisely, exactly on the spot of where we want to treat. So to put it all together, when we use the C-plan treat way, where we will really titrate the dose to the size of the area, and we'll calculate the dose to make sure we've given exactly the right dose in every specific area, because you may need different transducers, so you want to add up the amount of energy that you've delivered, just like you'd know the amount of filler or radius that you've put in one specific area. And then we make sure that we've looked at the density, the distribution, the orientation, and the accuracy that we're on the target. And when you follow these guidelines, then treatments are almost always efficacious. I think all therapy failures are down to physician failures. If I look in the early days of the failures I had, it was not on the patient, it was on me. And I think that's true of a lot of the treatments that we do. So if you follow the right steps, you'll get the right result, and the treatments are efficacious and safe. And just to dispel the myth, they're completely comfortable if you are on the right target. My patients don't have analgesia. They score all therapy as a treatment somewhere around 2 out of 10, 10 being agony, and 0 being no discomfort at all. They score it on average at a 2. So these are the layers we're treating. How do we decide in each individual what to treat? So we know that everybody's layers look different when you scan them. As BMI goes up, the layers are thicker, they're further apart because the subcutaneous is thicker. In increasing age, as the skin gets thinner and as the subcutaneous gets thinner, the tissues get thinner. So those are rough rules, but everyone's an individual. You can find a 20-year-old with thin tissues. You know, there are no rules, which is why we need the live ultrasound visualization. And you can see that we can deliver different thermocoagulation points at different target layers, very specifically to fulfill the requirement of the patient. And our priority layer is the superficial fascia. Superficial fascia, the biggest layer that we want to treat is the SMAS on the face. That has the most thickness. But we also treat the superficial fascia on the frontalis muscle, on the orbicularis oculi. On the neck, it is the platysma fascia. And ideally, we want to treat the superficial layer. Why? Because the superficial layer connects through with the fibrous septae to the skin, and that makes one complete unit. It's a unified area that I want to try and tighten together. You'll see a better lift that way. And then what else do I treat? Do we treat layer 1, the skin, or do we treat layer 2, the fat pads, the superficial fat pads? I like to treat all of them. This lady had all of them, but just to show you the difference, I split the treatment over 2 sessions. So the first photo shows on the day that she had the fascia and the fibrous septae in the subcutaneous treated. The second photo shows the result from just treating the deep layers, so no skin tightening. I think we have who has a skin tightening device, something that can treat the dermis? Surely more than that. Dermal tightening, Morpheus 8, skin needling, HIFU. No? You're very shy. I know you've all got them. So most energy-based devices treat the dermis. It's 1.5 millimeters. Terrifyingly, things like Morpheus 8 go deeper blindly. So you're putting such aggressive heat into the tissues, so fractional radiofrequency. Every device has a different depth, but you don't know what depth you're at. And the beauty with ultherapy when you're in the dermis is you know you're at 1.5. But I wanted, in this example, to take away the dermis. Don't treat the dermis yet. Let's see what happens when we only treat the deep layers, which can only really accurately be accessed with ultherapy prime. So you can see that the changes from treating the deep layers, this is the middle picture, the before and after 3 months, show that she has a general lifting and tightening. But what I found really interesting is that her nasojugal groove improved, her tear trough improved, just from moving, no skin tightening here. This is all just the superficial fat and the fascia. So you can see the majority of the improvement in this patient came from treating the deep layers. Then we treated the dermis at 1.5. She had dermis 1.5 to 2 millimeters, so that was perfect for ultherapy. And you can see that she had an improvement in skin quality and a further improvement to the result. Now, if I could have waited, she had some other treatment, she wouldn't wait. But if I could have waited, the result would have got better because the skin generally takes longer to regenerate than the deeper layers because the skin sees the light of day. So it responds a little bit slower to the regeneration. So what I treated in this patient was the superficial fat. It was saggy fat. I mean, it's not just that our skin gets lax and our fascia gets lax. Our fat is structural. It has fibrous septae that run throughout it. And fibrous septae degenerate with age, so our fat gets saggy. I mean, we do feel it on our bodies, but what we're seeing is saggy fat on our faces. It's not just skin laxity or ligamentous laxity. So what I did with this lady was treat her saggy fat. But I didn't treat the fat, I treated the fibrous septae. And with ultherapy prime, that visualization is so sharp that you can really quite accurately find the fibrous septae and treat them and spare treating anything else. So this study shows that the fibrous septae degenerate. This is an MRI scan of the fibrous septae in a cheek. On the left, it's a cheek that has mild sagging, and on the right, it's a cheek with conspicuous sagging. And the fibrous septae degenerate. You can see they're few in number, they're broken, they're discontinuous, they're thinner. And it was shown that they have less collagen and elastin in them as we age. So this is also a target for our regeneration, and I believe when we put hyperdilute subdermally, some of it does diffuse down into the subcutaneous layer, and you see when you scan with ultrasound that the fibrous septae are thicker after radius dilute and hyperdilute treatments. Now, our aim is not in the midface usually to increase the fat layer, but in the lateral face, when we're using hyperdilute or dilute radius, we want to increase that subcutaneous space. I'll sometimes do that if a patient's tissues are too thin for ultherapy, and I want to thicken the subcutaneous layer and the dermis, so I'll prime them with a radius treatment first, and then scan them again, and you see that the subcutaneous space increases, but you note that the fibrous septae are thicker. So we can treat fibrous septae not only with ultherapy, but we treat them with radius, and I combine that frequently. So the fat pads that I like to treat are the nasolabial fat pad, because everybody loves to hate it. And we also treat the malar fat, the jowl fat, the upper jowl fat, the lower jowl fat, and the submental jowl. And we treat the superficial middle cheek fat. Not in every patient, just only if a patient has a problem in that area. So it's like fillers, you don't put them in a whole face. You put your doctor's hat on and you diagnose, and that's what we do with ultherapy. We treat strategically and specifically. We can also treat ligaments. Now, this is not in the standard guidelines, but certainly with the new ultherapy prime visualization, you can see the ligaments, and the retaining ligaments, our other speakers have spoken about them. We get laxity in them. The ligament, a true ligament, arises from the bone and comes up to the dermis. We also have areas of thickening and adhesions that get lax. And so with ultherapy, we can find these key collagen-rich areas, and we can treat them at various points, and you will see an immediate lift of the cheek. Now, that is an immediate lift caused by contraction of the collagen because we put some heat in it. But it's also confirmation that you hit the target. It's instantaneous, and it only needs a couple of shots when you're accurate. And then 3 months later, they'll actually get the result. So to look from the inside of the ligaments, you're all familiar with where they are, but I just wanted to, for those of you who do all therapy, to just focus in on this, that if you're in the wrong orientation, you won't find a ligament. So for example, if we think about the mesenteric cutaneous ligaments, they're in a vertical line down the face. So if my transducer is horizontal and I'm between the ligaments, I won't see them there. And this is why orientation is key and why visualization is key, because I can't find a target if I can't see it. So if those are my mesenteric cutaneous ligaments and I have my transducer vertically in the right place, bingo, I see them, I can treat them, you can improve the lift of a jowl, as an example. We do lots and lots of under-eye lifting, and our targets here are the zygomatic ligament and the lateral orbital thickening, if we're talking ligaments. Obviously, I have all therapy, so I'm also going to tighten the SMAS underneath. I'm going to tighten the orbicularis oculi fascia in the infraorbital region. I will look at the fibrous septi in the subcutaneous, and I'll treat the dermis if it's thick enough. But generally in the infraorbital area, it's too thin for all therapy, so you're treating fibrous septi, but you see a really good under-eye lift. So, on the left is what we generally do in a full facial therapy. All 3 layers full face. That would be my ultimate. But not every patient can afford it. Not every patient needs it. And so we can now start thinking a little more like we do with fillers, where, you know, they do on the stage, they give 5 injectors 1 ml, and they say, now you have a competition. See what is the best result that you can give with this 1 ml of filler. And everyone's so proud of how much they can do with just 1 ml. So I'm so proud of how much I can do with just a few shots of all therapy because I put them in the right place. And this is what super personalized treatments are. We worked out that there are key areas in the face where you can treat fibrous septi and ligaments, and dermis and SMAS if needed, but they're key areas in the face where most patients see most problems, and that if we allocate our oral therapy really specifically, we can have an elevated response. This is more for less. And who doesn't want to have a greater result for less effort and less financial input? We do them as 3 treatments, 6 weeks apart. So this is also great for your patients psychologically because they come 3 times to the clinic. We sell a course of 3, and they're coming back at 6 weeks. You have a chance to catch up with them, to assess how they're progressing. Are they on track with regeneration? Do they need a bit of extra help? Are they above average? And it's really good for patient relations. And by the time they've coming back for the 3rd soundbite, you're 3 months after the first, so you see the result coming already, and yet it's going to get better. Our patients come now every 6 months for small sound bites because they elevate the aesthetic response to everything that we do. Who doesn't want more lift under their eye? Who doesn't want their nasolabial fat pad to be more refined? Who doesn't want their jowl to be more elevated? And sound bites are more than that. You can sculpt an eyebrow. You can do a very strategic jawline lift using the mandibular septum. So I am not saying that I wouldn't rather do a big oral therapy, but I am saying that I'd like to be a designer as well. So this just shows you the areas in which we do them and the areas we apply them. If I am doing a full oral therapy treatment, I might also pick some of these strategic areas just to elevate the response. So I'll pick off these small sound bites, the ones that are needed in an individual patient, and then I'll progress immediately through to the whole treatment. So it's a finesse. I was speaking somewhere and they called it the appetizer to the main meal. But actually, sometimes, you know, when you go to a function and you just get full up eating the appetizers, you can actually just use the appetizers as standalone in certain patients. So this is the sort of thing that you can do. This is just a very small treatment. For those of you that don't know oral therapy, 100 lines is about 1/10 of the size of a treatment I would do on a full face. So a full face oral therapy might cost a patient, a really big one, and I do big treatments, might cost a patient 4,000 euros. Anything from 2,000 to 4,000 euros. This, each time the patient is paying 300 or 400 euros, 3 times. So for about €1,000. And you can see the sound bites that I did. And the concerns the patient had was the jowl, mainly the jowl and the nasolabial. And she refused to have any other treatment apart from a null therapy soundbite because she'd read about it. And she's one of those patients that come and they've already diagnosed and prescribed their own treatment. You know what I mean. And she wouldn't move. So I did the treatment. Well, Dr. Gosha, my colleague in the clinic, did it. And the result was more than she would have got, we believe, if we delivered that number. So in total, 300 shots of energy. If we gave her 300 in one go, it wouldn't have given her that result. So sound bites allow you to put it where it's needed. Just like filler in the right place will give you a much more potent result. This patient had a very similar concerns, but she had more laxity. She was a decade older, and she'd been in not such good health, and so we gave her a little bit bigger dose. We increased the dose, so it was 120 lines, still only 400, 450 euros a treatment, so still not huge. And again, we wanted to lift the jowl, she wanted the marionette to lift, the apple of the cheek, and the nasolabial fold. And you can see, if you just tune into where the apple of her cheek, do you know what I mean by apple? Is it an English expression, apple of the cheek? Like when the cheek is nice and round and lifted and juicy, like a juicy apple. So she wanted us to lift the apple of her cheek, and you can see that the apple lifted. And the patient can see it, because I've directly addressed her concern. She has skin laxity everywhere, but she didn't want a full therapy treatment. And the one I gave her addressed specifically her concern. So this patient, we also treated the infraorbital area. She had all the other concerns, because most of us do, nasolabial, jowl, apple cheek, but she wanted the infraorbital. In fact, she wanted me to fill her tear trough, and I just would not. She was too young. I very rarely fill a tear trough. I prefer to regenerate tissue so the tear trough resolves itself. And most tear troughs that patients think are tear troughs, as you know, it's a nasojugal groove and a palpebromalar groove, because you have ptosis of the cheek. And so you can see that she had an elevation of the lateral brow, a reduction of her tear trough, a lifting of her apple cheek, and an improvement of her marionette. She had a small amount of radius, one radius, a little bit of radius plus down at microbolus is on the right zygoma, because her right zygoma was smaller than the left. So the radius was for a treatment of asymmetry. And there was some hyperdilute laterally for skin quality. And the thick lines you see down into her cheek are something I do, which I call them radius threads. Threads in inverted commas. It's radius plus in a long line anchored at the lateral part of the zygoma. And alone, that treatment gives you an elevation of the cheek. But when you couple that with therapy, wow, you get a really improved repositioning of the tissue. So she was happy because she was more symmetrical, she didn't need tear trough filler, and these were small treatments. She's a young lady, only 34, 1.5 ml only of radius plus, and 3 small treatments. 220 lines is a very small treatment. Altogether, 660 lines, which isn't even the equivalent of a whole treatment. So, not in my book. So small treatments in a younger patient gave good results. This is how we use it in clinical practice or therapy. Someone might have a full face, or we use it as a sculpting tool. This patient didn't like her nasolabial folds. Her right nasolabial was fuller than the left. She wanted a lateral brow lift. She didn't like the asymmetry of her lip. It was drifting to her right side. And she wanted me to improve what she thought was a tear trough without filler. We did use a little bit of filler on her mandibular angle and some radius to support her regeneration, but the only place she had therapy was in these strategic soundbite zones. And I don't believe I could have given her that result without it, because she still would have had the asymmetry of her nasolabials. She wouldn't have had a lift and a repositioning of the soft tissues of her face. So I find that therapy for me is an essential tool to enhance the quality of the results we give. I do use a lot of ultherapy with radius, and these are just examples of the kind of things I'll do. Every patient's individual. We never use the same recipe twice, do we? But we'll use radius in multiple dilutions and distributions, and we'll use ultherapy over the top, either the whole lower face, or we'll focus in front of the red line of ligaments. So for example, the middle, number 3, she had a heavy nasolabial and a jowl, so we used more neat radius to lift as neat threads, and she had more ultherapy in the subcutaneous in front of the red line of ligaments to condense and contract the soft tissues of the face to give her a more refined result. So this is one of my staff members, as it happens, and she was only 30, and who knew she even needed treatment, but I needed a model. So she was there, and she had a relatively small ultherapy. So you're getting to know 270 lines is like a half an ultherapy, if that. Small ultherapy and some radius. But look at the sculpting she got. Now, I know that in my hands, I couldn't have given her that sculpting with radius alone. Because in my experience, and I've measured this, I've measured it with Vectra, I've measured the volume redistribution. You redistribute volume with ultherapy by contracting the deep layers of the face, and it lifts the volume up. And the patients often say, wow, even if they haven't had radius and only they've had ultherapy, they say, wow, it looks like you filled my cheeks. So I'm using the patient's own tissue and I'm repositioning it. And I tell my patients, it's like Spanx for the face. And in the UK, they own those Spanx. I don't know if you have Spanx here. Do you know Kim Kardashian? Do you know Skims? Okay. And all your patients wear Skims because not all your patients, they have sagging on their bodies. And we need to give them Skims for the face, and that's how I use ultherapy.
Thank you so much, Julia. It was really interesting and I hope inspiring for a lot of new users of ultherapy. So if you want to take a seat. I have 2 questions for you. Okay. And one for me is very important because I'm really afraid of pain. So what about pain while doing ultherapy treatment to your patient?
I'm not afraid of pain in life, but I'm also not afraid of pain with ultherapy patients because they don't experience it. I have many people tell me about their experiences with ultherapy that the patient had pain. And when they show me the anatomy of the patient, it's clear that they treated too deep. So ultherapy delivered correctly does not cause pain.
Great.
It's the fault of the practitioner, I'm sorry to say, if it's painful.
As in many other situations, and we know it. Last question, it is about another kind of medical device, which is needle radio frequency. So is it an alternative to microfocus ultrasound, or is it a totally different...
I'm so sorry, I couldn't quite understand the question.
Needle radio frequency.
Needle radio frequency, okay, yes.
Is it comparable, different? How do you compare it to ultherapy?
The only comparison is that it's fractional. So both devices deliver fractional energy, but there are many differences. Fractional radiofrequency treats majority of the dermis. And if you're deeper than the dermis, that worries me because you're in the subcutaneous fat, and fractional radiofrequency delivers aggressive energy and you do get fat loss with it. Whereas ultherapy is microfocused and the energy is very precise and the heat does not diffuse, so it protects the fat. So they're totally different devices, and really fractional radiofrequency has a place in many clinics, but it doesn't treat the deeper layers. And only ultherapy can treat and sculpt those deeper layers.